Let me ask you something, and be honest with yourself. Have you ever sat in the bathroom for 30, maybe even 60 minutes, feeling like you need to go, but nothing happens? You can feel it there, the pressure, the discomfort, but your body just won't respond. And then you give up, walk away frustrated, telling yourself, I'll try again later. But later comes, and the same thing happens again and again. If this sounds familiar, this is not just constipation, and it's not something a simple home remedy will fix. My name is Dr. Michael Adney, and today I'm going to explain what it really means when stool gets stuck in the rectum, why this is far more serious, especially after 60, and exactly what you should do step by step. We'll be talking about real anatomy and real solutions. It may feel uncomfortable, but your health comes first. If this feels even slightly familiar to you, I want you to type yes in the comments right now. You're not alone in this, and it helps more people. Find this video who are struggling silently. What is actually happening inside your body? Let me paint a picture for you. Not a textbook picture, but a real-life one that I hope makes this immediately click. Imagine a long, winding river. For years, that river has flowed beautifully. The water moves steadily, everything downstream gets what it needs. Now imagine that over the course of a week, very gradually, very quietly, the water slows down. Maybe there was a dry spell. Maybe some debris began to pile up in a narrow section. The river does not stop overnight. It just slows and slows and slows. Until one day, the debris has compacted so tightly at one particular bend in the river that the water literally cannot flow through anymore. That is your colon. That is what is happening right now. The medical term for this is a fecal impaction. But let me tell you what that actually means in plain language, because I think the clinical term lets people underestimate just how serious this truly is. Your large intestine, your colon, is essentially a muscular tube. Its main job is to move waste material toward the exit while simultaneously absorbing water from that waste. Under normal, healthy circumstances, this is a beautiful, almost automatic process. Waste moves, water is absorbed, stool stays soft enough to pass comfortably. But here is where aging changes the game significantly. And this is something I want every person over the age of 60 watching this right now to truly internalize. As we get older, several things happen simultaneously in the digestive system. The muscular contractions that propel waste through the colon, those rhythmic squeezes called peristalsis, slow down. The nerve signals that coordinate those contractions become less efficient. Thirst sensation decreases, which means many older adults are chronically mildly dehydrated without even knowing it. Medications, blood pressure drugs, iron supplements, calcium channel blockers, certain pain medications. Many of the most common prescriptions for people our age directly slow down bowel motility as a side effect. Put all of those factors together, and you have the perfect internal environment for stool to move through the colon too slowly, sit in the lower segment too long, lose too much moisture, and transform from something soft and manageable into something hard, dry, and essentially immovable. By the time it has been sitting for 5, 6, 7 days without passing completely, it has dehydrated into what can only be described as a dense, solid mass. And when that mass reaches your rectum, the final storage section just before the exit, and it simply cannot fit through, you have a fecal impaction. The pressure you feel is real. The exhaustion from straining is real. And the fear that something is seriously wrong is also completely justified, because something is seriously wrong. If you're learning something new right now, take 1 second and hit the like button. Segment 2. Why this is far more dangerous than you think. I want to spend some real time here, because this is the part that catches people completely off guard. People hear the words constipation and think inconvenient but harmless. A fecal impaction is neither of those things. Let me walk you through what begins to happen inside your body when a large, hardened mass is stuck in your rectum for an extended period. The first issue is structural pressure. Your rectum is not designed to hold a cemented, dehydrated mass indefinitely. It is a flexible structure, yes, but it has limits. When it is chronically overdistended, the blood supply to the tissue lining the walls of the rectum becomes compromised. The cells that line that wall need oxygen and nutrients from blood. When circulation is cut off or significantly reduced, those cells begin to struggle. In severe or prolonged cases, this can progress to tissue injury that requires medical intervention to repair. Now, here is something that genuinely surprises most people when I explain it in clinic. Your rectum and your urinary bladder are neighbors. They share a very confined pelvic space, separated only by a thin fibrous wall. When your rectum is packed with a solid, rigid mass and stretched well beyond its normal capacity, it physically pushes against the bladder. For women, this pressure is often more pronounced due to pelvic anatomy. What patients experience is a sudden and confusing difficulty urinating, a feeling of constantly needing to go but only passing a few painful drops, or in severe cases, not being able to urinate at all. I have had patients who came into my clinic genuinely convinced they had developed a bladder infection overnight. The real cause was a rectal impaction compressing the bladder from behind. Once we addressed the impaction, the urinary symptoms completely resolved. But we are not done yet. There is one more symptom that I must warn you about specifically because it confuses people so profoundly that they actually end up making things dramatically worse. It is called overflow incontinence, and it looks on the surface exactly like diarrhea. Here is what happens. The solid mass blocks the main exit, but your intestines are still producing liquid waste higher up in the digestive tract. That liquid has nowhere to go except to seep around the outside edges of the hard blockage, like water finding a crack in a dam, and leaks out unpredictably. People see this liquid and think, well, I clearly do not have a blockage, I am having diarrhea. And some people, tragically, go to the pharmacy and buy an anti-diarrheal medication to stop it. This is one of the most dangerous mistakes you can make in this situation. Anti-diarrheal medications shut down the movement of your intestinal muscles. You will paralyze the very mechanism that your body is using to try to work around the problem, and you will cement that impaction even more deeply into place. I strongly recommend you save this video right now. You may not need it today, but if this ever happens to you or someone you love, having this step-by-step guide could make all the difference. If you are experiencing what appears to be diarrhea alongside days of feeling like you cannot fully empty, please consider the possibility that it is overflow, not true diarrhea, and do not medicate it without speaking to a doctor first. Segment 3. Why seniors are at dramatically higher risk. I want to speak very directly to my older adult viewers here, because the statistics on this are sobering and rarely discussed in mainstream health content. Fecal impaction is not evenly distributed across the population. It disproportionately affects adults over 65, and the risk increases significantly with each decade of life beyond that. In nursing home and long-term care settings, some studies suggest that fecal impaction affects upward of 40% of residents. It is one of the single most common gastrointestinal emergencies in geriatric medicine. Yet it is also one of the most preventable when people understand what creates the risk in the first place. Let me give you the major risk factors specific to older adults. Reduced mobility is enormous. When we move our bodies, walking, exercising, even just standing and doing light housework, we are mechanically stimulating the digestive system. The simple act of walking creates gentle, rhythmic pressure in the abdomen that helps keep intestinal contents moving. When mobility decreases due to arthritis, a recent surgery, a fall, or any other reason, that mechanical stimulation disappears. The colon slows down. Dietary changes are another key factor. Many older adults find their appetite decreasing. They eat smaller meals, they may eat less fiber, they may drink less water, partly because the thirst mechanism that tells us we are dehydrated becomes less reliable with age. All of these changes reduce the bulk and moisture content of stool, making it more prone to hardening. Then there are the medications. This is a conversation I encourage every person over 60 to have with their doctor or pharmacist. Many of the most commonly prescribed drugs for older adults have constipation as a direct side effect. Opioid pain medications, certain antidepressants, antihistamines, iron supplements, calcium supplements in high doses, diuretics that increase fluid loss. If you are on multiple medications, which many of my older patients are, the combined constipating effect can be significant. Finally, there is the issue of suppression. Many older adults grew up in an era where talking about bowel habits was deeply taboo. They feel the urge to defecate, but they are not at home, or it is not a convenient time, so they suppress it. They waited. Suppressing that urge over months and years retrains the rectum to be less sensitive to the signal. The urge becomes less frequent, less urgent, and waste sits longer. Understanding your own specific risk factors is the first step toward preventing this situation from ever repeating itself. Before we go into the exact step-by-step solution, make sure you're watching this in a place where you can focus, because what I'm about to show you could help you avoid an emergency room visit. Segment 4, the Emergency Action Protocol. Alright, you now understand what is happening and why. Now let us talk about what to do if you are in the middle of this situation right now. The very first instruction I want to give you, and I want you to hear this clearly, is this: stop straining. I know it feels instinctive. I know your body is screaming at you to just push harder, push more, try a different angle. But here is the physiological reality. A solid, dehydrated impaction does not respond to pressure from above the way normal stool does. It is too rigid. What additional straining actually accomplishes is increasing the risk of causing hemorrhoids, anal fissures, or even a rare but serious condition called a vulvotopsy, a sudden drop in blood pressure from excessive straining that can cause fainting. In older adults with cardiovascular conditions, aggressive straining can also place dangerous strain on the heart. Stop straining, breathe, and let us work through this systematically. Step 1. Glycerin suppositories. Go to any pharmacy, no prescription needed, and purchase adult glycerin suppositories. For a hardened impaction in an adult, a single suppository is often insufficient. In consultation with a healthcare provider or following established clinical guidance, many practitioners recommend using 2 to 3 adult-strength suppositories simultaneously for an established impaction. Here is exactly how to administer them. Lie on your left side, not your back, not sitting upright, but your left side. This position works with your anatomy. Specifically the natural curve of the sigmoid colon and rectum to direct the medication toward the mass. Apply a generous amount of water-based lubricant to each suppository before insertion. Do not skip this step. The surrounding tissue is already irritated and sensitive. Lubrication is both more comfortable and more effective. Insert the suppositories gently and deeply. Breathe slowly and steadily. And this is the part where most people fail, do not move. Stay on your side. Stay still. Wait a minimum of 30 to 45 minutes. Set a timer if you need to. Glycerin works by drawing moisture into the stool from the surrounding tissue through osmosis, and by lubricating the rectal walls. It needs time to soften the outer layer of the mass before anything can move. If you rush to the toilet after 10 minutes, you will very likely only expel the suppository itself, and the impaction will remain exactly where it is. Step 2. The second attempt. If after that first round nothing significant has passed, do not despair and do not immediately push. Get up gently. Walk slowly around your home for 15 to 20 minutes. Gentle movement stimulates peristalsis. Then lie back down and repeat the process. Allow another full 30 to 45 minute window. The second round of glycerin is often what is needed to soften not just the outer layer, but to penetrate further into the mass and allow it to begin breaking up. Step 3. Warm water retention enema. If 2 rounds of suppositories have not produced results, the next step before seeking emergency care is a warm water or saline retention enema, available over the counter as a Fleet or similar product. Follow the instructions carefully. Lie on your left side, administer slowly, and again, hold it. Do not rush. The goal is to introduce enough fluid and warmth to further hydrate and loosen the impaction from above. Step 4. Emergency medical care. If all at-home attempts have been thorough and unsuccessful, and I want to stress, because patience is truly required here, it is time to go to an urgent care facility or emergency room. This is not admitting defeat. This is making a smart, rational medical decision. At the hospital, the clinical team has access to high-volume therapeutic enemas with medicated solutions that penetrate much more deeply into the colon than anything available over the counter. They have imaging capability to assess exactly how extensive the impaction is and whether it extends beyond the rectum into the sigmoid colon or further. In cases where clinical enemas are insufficient, and this does happen, particularly with long-standing impactions, a specialist will perform what is called manual disimpaction. I want to be straightforward with you about this. It is exactly what it sounds like. A physician using protective gloves and substantial lubrication manually breaks up and removes the impacted mass, piece by piece. Because the surrounding tissue is extremely inflamed and sensitive by this stage, this procedure is typically performed under sedation or regional anesthesia. It is uncomfortable to hear about, I know, but it is a safe, routinely performed clinical procedure, and the relief patients report immediately afterward is, without exception, extraordinary. Segment 5. Recovery and what happens next. Once the impaction has been successfully cleared, either at home or with medical assistance, your body enters a brief recovery phase that requires your attention and care. For the first 24 to 48 hours, the rectal tissue is irritated, swollen, and sensitized. You may experience some discomfort, light spotting, or a feeling of rawness. This is expected and will resolve with time. A warm sitz bath, soaking the lower portion of your body in warm water for 10 to 15 minutes, 2 to 3 times a day, provides significant relief and promotes tissue healing. Your diet for the first few days should emphasize easily digestible, soft, fiber-containing foods. Think oatmeal, cooked vegetables, ripe bananas, soups with soft vegetables. Avoid anything dry, tough, or low in moisture, and drink water consistently, deliberately throughout the day, even if you do not feel thirsty. This is also the moment, while the memory of this experience is fresh, to make some appointments. Book a visit with your primary care physician to review your medication list, specifically for constipating side effects. If constipation has been a recurring pattern for you, ask for a referral to a gastroenterologist who can evaluate your colonic motility more formally. And if you have not had a colonoscopy within the recommended time frame, this is an important time to ensure that structural causes, such as a narrowing of the colon or growth affecting the passage, have been properly evaluated. Now, tell us in comments about your health condition, with your age. I will reply to every single comment. And if you found this helpful, press that like button and subscribe to the channel. Segment 6. Long-term prevention, the foundation. I want to close today with the most important thing I can possibly tell you. What we have discussed up to this point has been crisis management, and crisis management, while critically necessary, is never the goal. The goal is to build a life in which this crisis never happens again. Long-term prevention of fecal impaction in older adults rests on 4 pillars. Pillar 1 is hydration. Water is the single most powerful tool your colon has for keeping waste soft. Aim for at least 6 to 8 glasses of water per day. If plain water feels difficult, warm herbal teas, broth-based soups, and water-rich fruits and vegetables all count. Set alarms if you need to make it a deliberate habit. Pillar 2 is movement. You do not need to run a marathon. A 20 to 30 minute walk daily is genuinely one of the most powerful things you can do for your digestive health. If walking is difficult, even gentle chair exercises or swimming can help maintain intestinal motility. Pillar 3 is dietary consistency. Soluble fiber from oats, fruits, legumes, and cooked vegetables adds bulk to stool and retains moisture. Introduce fiber gradually if you are not accustomed to a high-fiber diet to avoid gas and bloating. And make meals a consistent routine. Eating at roughly the same times each day helps your intestines develop a rhythm. Pillar 4 is scheduled bathroom time. The gastrocolic reflex, the natural signal your colon sends to prepare for a bowel movement after eating, is strongest in the morning, often within 30 to 60 minutes of breakfast. Sit on the toilet at this time every single morning, even if you do not feel an immediate urge. Use a small footstool to elevate your feet slightly. This places your body in a physiologically optimal position for elimination. Give yourself 5 to 10 minutes, without rushing, without straining. Over time, your body will relearn this rhythm. Do not rely on stimulant laxatives as your long-term solution. I understand the appeal. They work, they are accessible, and they provide relief quickly. But long-term daily use of stimulant laxatives trains your colon to become dependent on artificial stimulation. When you stop taking them, the colon has largely forgotten how to initiate movement on its own. This is called cathartic colon, and it is a real and documented consequence of long-term laxative overuse. There are far safer options: osmotic agents, stool softeners, fiber supplements that your doctor can recommend as part of a sustainable plan. I know this was a long conversation today. I know some of it was not easy to listen to, but I believe deeply that the most important health conversations are often the ones that feel the most uncomfortable to have. You deserve to understand what is happening inside your own body. You deserve a clear plan when something goes wrong, and you deserve to know that whatever you are going through right now, you do not have to figure it out alone, and you certainly do not have to be embarrassed about it. And you certainly do not have to be embarrassed about it. If you found today's video genuinely useful, I would ask you to do one thing: share it. Send it to a family member, a friend, a neighbor, anyone in your life who might be quietly suffering with this and not saying a word about it. This video might be the exact resource they have been looking for, but did not know how to ask for. Click the like button if this helped you, subscribe to the channel so you never miss our upcoming videos on digestive health, longevity, and taking real control of your health as you age. Take care of yourselves. Drink your water, move your body.